Hi everyone, we're going to talk about Chapter 20, Cognitive Perceptual Disorders. Let's start with the definition of cognition, and that's the acquisition, processing, and use of information. We know that when there's problems acquiring or processing or using this information, that there can be issues for the child. There are three things that make up the cognitive perceptual components, and that includes memory, which is encoding and storing and retrieving; representational competence, which is creating or manipulating mental images; and then attention, which is your focus or your shift of focus. And then what pulls all three of those together is the processing speed of that information. Cognition and knowledge is the accumulation and the reorganization of experiences that are formed from being in a stimulating environment. And then perception is the organization, identification, and interpretation of the sensory information that is needed to understand the environment. Traditionally, the focus of learning had been on visual or audio input, and now that's being expanded to include sensory input. And this includes vestibular and proprioception components that are felt to be critical to learning. One theory that is associated with cognitive development is Piaget's cognitive development theory that includes key concepts such as assimilation, which is taking in information through all senses; accommodation, which is taking one's current situation and modifying it to adjust to the new circumstances or the challenge; schema, which is organizing things into a new mental structure; and an equilibrium, which brings you to a new level of cognition. Other theories include information processing, and this is another way to describe thinking or problem solving. It looks at intellectual capabilities such as how the information is presented, processed using transforming information, and what memory limits that can limit the amount of information that is represented and processed. A key component to this theory is if a child fails to identify or comprehend critical elements, then they don't know how to encode these for future knowledge to help them with potential experiences. Social cognition, it's the spectrum of social behaviors and helps us with affiliation with others. It is called your intuition or common sense, and it's your ability to interpret behavior or emotions of the self and others. There are certain social cognition developmental skills for each age cluster, and I encourage you to look in Chapter 20 for that. But just for an example, in infancy, it may be eye contact. In a toddler preschool age setting, it could be empathy. In school age, learning how to be street smart; in adolescence, identifying sexual identity. So review those in the book. So there's neurodevelopmental functioning. It's a framework of learning that helps clarify how the brain functions and how these functions affect student learning performance. Each individual has strengths and weaknesses that influence learning, and learning more about those can help describe, organize, and address individual children's learning needs. In your book on Table 20-1, there's a great section called Constructs of the Neurodevelopmental Learning Framework, which will give a construct and then give a description of it. I encourage you to review that. Then, as part of cognitive development, there are multiple intelligence, and a physician by the name of Dr. Howard Garner in the mid-80s identified 8 different intelligence to account for a range of abilities of learning. That's on Table 20-2. It describes different intelligence such as linguistics, logical, musical, spatial, body or kinesthetics, social or interpersonal, etc., and gives more of a description of the different types of learning that will go on with a child that has those different intelligences. So I encourage you to look at that as well. There are certain screenings that are performed, and these are supported by the Healthy People 2020, and they include both visual and hearing screenings in children. We know that these screenings are helpful to determine if the child is ready for school. They also address the child's ability to have educational achievement, as we know that if a child has difficulty hearing or seeing in the classroom, that's going to impact their learning ability. And we also screen for any individual on the autism spectrum and assess for any developmental disorders. So, early identification and intervention for any problems with cognitive health is very important in this developmental time. Also, in the cognitive perceptual development, Piaget's cognitive development theory comes out, and there's a couple of components of this that we're just going to review, where we have assimilation, which is taking in information, accommodation, which is taking what is currently available and being able to adapt it or understand it for new circumstances. Schema is the organization of the mental structure that is being perceived, and equilibrium is a new level of cognition. We're going to talk about a few theories that impact cognitive perceptual development. The first is information processing theory. It's a way of looking at how individuals problem solve. It assesses their intellectual capabilities, such as how information is presented, processes used to transform this information, and any memory limits that might constrain the amount of info that was presented and processed. Some structural components include sensory, which includes your visual and auditory perceptions, short-term memory, and long-term memory. Now, the short-term memory can be considered like your CPU of your computer, and the long-term memory can be considered similar to the hard drive storage of your computer. There are several processing components in the information process theory, and these include rehearsal activities. This keeps information in the short-term store, and so social cognition is our intuition or our common sense. It's our ability to interpret behaviors or emotions that we perceive from others. It has several components, and those are based on our ability to be able to do certain things, such as understand thoughts, follow rules of social play, regulate responses in social environments, anticipate how others may feel based on a certain circumstances has occurred, communicate and understand social meaning, and understanding body language or perceptions of different facial expressions. We've gone over some of this previously, but I want you to be sure and look in the book for the spectrum skills that are needed at different clusters in the child's development. I think we're having some duplicate slides in this pack, but we discussed this previously. Look at table 20-1, and then the multiple intelligence. We discussed those, and that is on table 20-2. So let's talk a little bit about executive functions and the prefrontal cortex. These are skills that are needed to organize goals and to learn in school. The prefrontal cortex helps us organize and regulate information. It helps us to focus on what's the most important part of that information, to not focus on or to suppress irrelevant stimuli. It helps you to draw on memory to understand that stimuli if something previously might have impacted it. It helps to plan for future goals and consequences, and helps regulate emotional and behavioral responses. Components of self-regulation include inhibition, which is the stop or delay of the first response, interruption, which will help make a brief pause in inappropriate behavior, resistance, helping to not be distracted, and flexibility is the ability to shift between activities and thoughts. Metacognition is the ability to think about thinking or knowledge from past experiences and merge those with new challenges. So you would use this to reflect, plan, and execute what might need to be done. You would see that it would be have organization, may be insightful, make logical decisions, and complete complex activities in metacognition. Components of it include the working memory, problem solving, and monitoring. Okay, so let's talk a little bit about sensory processing. It's the integration of information from different senses, and we know that there are different processes that can occur with all of our senses, such as our vision, hearing, touch, taste, smell, positioning, and movement. So we have sensory modulation, which is the regulation of the responses, sensory description, which is an interpretation of the stimuli and would include intensity, duration, spatial or temporal elements. And then we have sensory-based motor, which includes more about balance and core stability, as well as planning and sequencing movements. There are certain skills that are needed for academic success, and these include social and emotional skills as well. There have been 5 skills or competencies that have been identified to play a role in shaping how students achieve and what their future success as adults may be. And these include self-control, which is managing emotion or behavior, persistence, mastery orientation, academic self-efficacy, and social competence. And you can see a little bit more about each of those there on the slide. Although each of these skills have their own specific characteristics, they all reinforce each other. Let's talk a little bit about the elements of learning. To learn, we need to have 3 components, and intelligence is our ability to learn and understand and to deal with new situations. It is often measured by tests that evaluate problem solving, language skills, attention, memory, and these are all critical for achievement in school. Learning is the ability to observe and to accommodate what is seen, and then language, memory, and attention are what we talked about previously that are critical in the school environment for achievement. So with language, we have we have listening and reading comprehension. We also have oral and written expression. In memory, there are 4 different types of memory. The first being 4 different levels of memory, first being short term. Then we have active working. We have consolidation in long term. And then we have retrieval from long term. And these all play a critical role in the learning abilities of the child as they move through school. Another process level in development is attention. And students need the ability to concentrate without distractions, and then to be able to shift focus if needed when learning. Some individual characteristics that are needed for academic performance include cognition, which is a predictor of success, having developmental skills, which help to support intelligence, resilience, contribute to the motivation to succeed, and then desire for education, believing that something is important and worth learning more about. There are also family characteristics that are important for a child's success. These include community acceptance of the family structure, family values, performance expectations, and parental academic abilities. Social factors also can impact academic achievement, and these include economy, politics, religion, and culture. Okay, let's take some of that and put it into what you would do to assess for cognition in your well child visit. So, as with everything, we know we need to get a good history. With this history, we want to consider any risk factors or anything currently that can impact the child's cognitive and perceptual development. So, you're wanting to assess risk factors based on any genetic, prenatal, or perinatal factors. These would include trisomy 21, if there was any physical malformations in the prenatal factors that you might be assessing. Could there be use of tobacco, alcohol, or other drugs at pregnancy, did mom have hypertension, things along those lines. You're wanting to assess for any fetal hypoxemia or any conditions that might have provided suboptimal growth. You're wanting to assess for any maternal depression during infancy. You're asking questions of some things that happened during preschool. How did the child interact with others? How well did they play with others? This is going to give information to how well they do in larger group settings, if there's been any lack of independent play or sustained interest in a preferred activity. And then in your school and adolescent age children, you're assessing for things that we've previously talked about, but you want to know how they've done in academic settings, any problems with interaction of peers, or in large group settings. You're going to want to do your standard screenings such as hearing and vision. You're going to do your developmental screenings throughout the first year, 6 years, to make sure that there's not any delays. And then you're also going to want to assess the child's academic progress. So if you have a child that has cognitive perceptual developmental issues, it's important to identify what the primary care responsibilities are. You want the child and the parent to believe that they are operating in a family-centered healthcare home that provides support for the child on what is going on. While they may be receiving services from other individuals, the PCP acts as a very important person as they anticipate issues that may arise in between visits with others. You are there to be the child's advocate and to help the parent and the child to understand more about what is going on with them. You'll be monitoring them on an ongoing basis. If medication is a part of the plan, then you will be there to help with that. You also may serve as a collaborator with other team members. So if a delay has been noted with your child, it's extremely important to get the child into early intervention services. If problems are noted, then these children are entitled to special education opportunities to help maximize their learning potential. Also, an IEP or an individualized educational plan is a means of accommodating the child's special learning needs. And then you're there as an advocate helping the child and the parent to identify and build upon their strengths that will help with their motivation and self-esteem. You are likely going to be there to have to help support the family, and there's several strategies that can help. The family can be the child's advocate. They can help with conferencing and monitoring. They are going to be the ones that will be out seeking more about education on the rights of the child and then exploring community support services. These kids often struggle with appropriate behaviors with other children and with their peers, and so you may be an advocate trying to help get them into groups that will allow them to learn how to get along with others better and develop better social skills. And you may be working with some form of case management to help with the integration of these services. Let's talk about attention deficit hyperactivity disorder, also known as ADHD. It's a common disorder in childhood and is considered to be a neurodevelopmental disorder. This disorder can have cognitive, educational, behavioral, emotional, and social functioning issues on the child. Some of the core symptoms include inattention, hyperactivity, and impulsivity. It's known to affect self-regulation and executive functions. These 6 executive functions include activation, focus, effort, emotion, memory, and action, and those are found in your book, and I encourage you to review those. In the book on table 20-4, there is a good breakdown of the different subtypes of this condition, and I encourage you to go through that. We're not going to go through that. There's various thoughts on the prevalence of ADHD in the country. But what I found interesting in the book is that the average age of diagnosis is 7, with children who have severe ADHD diagnosed earlier, and the prevalence varies substantially by state, with being as low as 5.6 in Nevada to as high as 18.7 mentioned here specifically in Kentucky. Boys are identified with a higher prevalence than girls, approximately 2 to 1, and girls are more likely to have the inattentive features. So I think I got behind on reviewing my slides. We've talked about this, and we've talked a little bit about this. There are some racial and ethnic disparities, and Hispanics and African Americans are less likely to be diagnosed. So let's talk a little bit about ADHD on individuals, families, and communities. We can only imagine that it's an increased stress on the family, as the symptoms can often persist into adulthood. These families are likely to report higher levels of stress. These activities are going to pose difficulties with peer relationships. There are significant direct and indirect costs, including days of missed work due to appointments, evaluations, and treatments. Often these may not be covered by health insurance, and the cost of medication and mental health care can definitely be an impact on the family. We know that attention is a multi-layered neurological activity that requires function and interconnection of different parts of the brain. No single cause for ADHD has been identified, but it's generally agreed that it's primarily that it's a genetic disorder with environmental factors. It is felt that between 75 and 91% have inherited the condition. There are less availability of some neurotransmitters in the brain in those individuals with ADHD, and it's known that both dopamine and noradrenaline are essential for healthy brain function, especially when maintaining alertness and attention. There's been some noted structural and functional differences in the brain structure, and there's a delay in maturation of the connections within the cerebral cortex. There is thought that there is a connection between the genes and the environment, and certain exposures during gestation and neonatal times can contribute significantly to ADHD. These include smoking or alcohol during pregnancy, prematurity, low birth weight, maternal psychosocial stressors, lead exposure, depression by mom, trauma during childhood experiences, and societal changes such as longer school days. Some clinical findings that you may see: difficulty with attention, activity, or impulsivity. The parent, some provider may comment on memory, emotion, and organizational difficulties. There may be social issues with friends, classroom issues, behavioral issues. So it's important to interview both the parent and the child. There are ADHD standardized assessment scales that can be used. As you are in clinicals now, I'd encourage you to speak with your preceptor and see what their practices are using. You may have already completed one of these assessments, so be sure and ask more about that, what's based in practice right now. It's important to do a good history and physical, and on table 20-6 there's an excellent history component of important things to ask when doing this type of evaluation. It asks such as birth history, medical history, general health, questions regarding ADHD history, developmental history, behavioral history, and academic history. It also wants to know more about functional health patterns such as nutrition, elimination, sleep, coping, family health history, and about the teacher history. So I encourage you to look at that. You're also going to complete a thorough physical exam. If you're working a child up for ADHD, then you're also, as we mentioned earlier, going to use some assessment scales, and you also need to have these completed by 2 adults from at least 2 different domains, whether it be school, home, or daycare, and these are going to give more information into what's going on with the child's behavior at different times during the day, and to also help monitor to response to any therapies that you're going to do. I am not for sure what's in the old book, but there is not a table 20-8 that gives some commonly used ADH tools, so don't go looking for that. That's why I was going to ask you to speak with your preceptors. Some other diagnostic tools may be your performance task measures. There's a quotient ADHD test which assesses for shifts in attention, and then there are some tests that measure the beta and theta wave ratios. We're not going to get into those things. Now it's time to talk about some differential diagnoses that you might consider for these kids that come in with the complaints that the parent or caregiver and or teacher has. These may include sleep disorders, learning disorders, any emotional or behavioral disorders, physical conditions, and then sluggish cognition. In the management of these kids, what's foremost is making a proper diagnosis. So you want to learn as much as you can about onset, duration, and what type of settings these symptoms are seen in. You want to know the degree of any functional impairment, if these symptoms are having issues and affecting the relationships or activities of the child, and then also trying to assess for the degree of inattentiveness, hyperactivity, impulsivity of the child. During your initial meeting with the parent and family or child, you're going to try to get a comprehensive discussion going on what the findings you have found. You're going to want to identify any difficulties that have been noted. At this time, you're going to want to provide as much information as you can for the child, the family, and to provide to the school. You're going to work on a plan of care that meets the needs, whether they're in the school or the home, and these are going to include short-term plans with target goals. You're going to want for the child and the family to have some specific measurable items. Let's say the book recommends approximately 3 that come from the list of the child's impaired issues that they can incorporate to help build on strengths and resiliency. And there's an excellent box in the book 20-2 of ideas for support of the family, and I encourage you to read those. The plan and care may also include pharmacological management, behavioral management, and then support services for functional areas that are needed. I know this video is going long, but we're going to try to finish up ADHD. Pharmacological management would include the stimulants as the first line of medications, and these would include methylphenidate and amphetamines. You're going to want to use, you may consider medicines that block the removal of dopamine and norepinephrine. You could see these in extended release or short acting release. It's important to start with lower doses for predominantly inattentive presentation. Use longer acting medications to prevent the need to dose during school, and there may be other conditions that are associated with preschoolers, so you may have to take that into consideration when choosing your line of medication. We're not going to go into the specifics of each individual medication, but in table 20-7 there's a great chart of the stimulant medications to use with ADHD. When prescribing these medicines, always be sure to start at a lower dose and titrate up every 1 to 3 weeks depending on the goal that you have set. Your goal is to maximize reduction of the symptoms and have minimal side effects that impact the child. And if you find that the maximum dose does not give the benefits that you want, you may need to change to another type or go to a non-stimulant. And when deciding on medications, it's important to consider the following. So, amphetamines are 1.5 times more potent than methylphenidate, and Vyvanse 30 milligrams can equal an Adderall 10 milligram. Focalin products are roughly 2 times more potent than regular methylphenidate products. So hopefully some of those tips might help you as you are considering what medication may be beneficial. And while you won't be prescribing unless you're psych NP, having more knowledge of this is important. Okay, more with pharmacological. There's important knowledge in the warnings and side effects and precautions of some of these medicines. It's important to assess for cardiac issues. They're not known to have any adverse cardiovascular effects. They shouldn't be given if the child has problems with an increased BP or if their heart rate is problematic. And then also, it's important to get a good family child cardiac history physical exam. For kids that might have tics, not bugs, but the tic disorders, it's important to know that children with ADHD may likely develop tics, and often these can be coexistent. And if the tics become more severe or worrisome, then that line of medication needs to be stopped. These medicines can also decrease appetite, can cause weight loss. There may be insomnia. Headaches may be common, but they usually resolve. But it's important to monitor for these things. One medication that we'll talk about is atomoxetine. It's a non-controlled, non-stimulant medication that's been approved for first-line use in kids with ADHD that are older than 6 years old. It is a norepinephrine reuptake inhibitor. It does have some warnings and side effects, contraindications. So you're wanting to assess for liver toxicities. It's important to test if you notice any jaundice or any symptoms of liver issues. You want to assess for suicidal thoughts or any attempts. If these occur, it's important to refer. And then you're assessing for any cardiovascular disorders, and you want to avoid its use if a child has high blood pressure. Other pharmacological management second lines include extended release guanfacine, which is intuitive, and an extended release clonidine, which is Capve. Behavioral management is important because it can occur as an effective supplementation to the medication. It is recommended to use behavioral management exclusive of medication if the child is younger than 6, the symptoms are mild, or if the DSM criteria are not met. It's important that there's assessment and education on parent skills management, including direction, goals, and limits. Behavioral management will also include cognitive behavioral therapy to include psychoeducation, direction, and new skills to help modify the behavior that is seen, classroom management to help improve attention and productivity in the classroom and decrease disruptions, technology assessment control, assessing the time used with computers, visual thinking tools, and electronic organizers. There'll be peer interventions. This is when a peer is paired with a child with ADHD to help reduce inappropriate or disruptive behavior. And there may be neurofeedback that retrains the brain. And I believe the last slide on attention deficit is talking about support services from home, family, friends, having positive activities, promoting good self-esteem, school management. You'll have follow-up care. This is going to include reassessment of the symptoms, assessing functionality and targeting goals, review of medication regimens, provisions for anticipatory guidance, and also further education, and when necessary, referrals. Okay, that's been a long part of this chapter. We're going to close this out and come back for about another 15 slides on finishing up the rest of this chapter. Thank you.